I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Good morning. This is the consensus statement developed by the panel on ECT, Electroconvulsive Therapy. Introduction. Electroconvulsive Therapy, ECT, is a treatment for severe mental illness in which a brief application of electric current is used to produce a generalized seizure. In the United States in the 1940s and 1950s, the treatment was often administered to the most severely disturbed patients residing in large mental institutions. As often occurs with new therapies, ECT was used for a variety of disorders, frequently in high doses and for long periods. Many of these efforts proved ineffective, some even harmful. Moreover, its use as a means of managing unruly patients for whom other treatments were not then available contributed to the perception of ECT as an abusive instrument of behavioral control. With the introduction of effective psychopharmacological medications and with the development of judicial and regulatory restrictions, the use of ECT in these institutions has waned. Treatment is now used primarily in general hospital psychiatric units and in psychiatric hospitals for the treatment of severe depressions, mania, and certain types of schizophrenia. A National Institute of Mental Health hospital survey estimated that 32,384 patients admitted to hospital psychiatric services during 1980 were treated with ECT, representing approximately 2.4% of all psychiatric admissions. Although ECT has been used for more than 45 years, there is continuing controversy concerning its efficacy, complications, the disorders for which it is indicated, the optimal methods of administration, and the extent of its usage in various settings. These issues have contributed to concerns about the potential for misuse and abuse of ECT and desires to ensure protection of patients' rights. At the same time, there is concern that the curtailment of ECT use in response to public opinion and regulation may deprive certain patients of a potentially effective treatment. In the recent decades, scientists have intensified research efforts to establish the effectiveness of ECT and its indications, understand its mechanism of action, clarify the extent of adverse effects, and determine optimal treatment techniques. This research effort has yielded substantial information that is relevant to the professional and public discussion regarding the safety and efficacy of ECT. In an effort to resolve questions surrounding these issues, the National Institute of Health, in conjunction with the National Institute of Mental Health, convened a consensus development conference on electroconvulsive therapy on June 10 through 12, 1985. After 1.5 days of presentations by experts in the field and discussion by the audience, a consensus panel, including representatives of psychiatry, psychology, neurology, pharmacology, epidemiology, ethics, and law, and the general public, considered the scientific evidence and agreed on answers to the following questions. What is the evidence that ECT is effective for patients with specific mental disorders? What are the risks and adverse effects of ECT? What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? How should ECT be administered to maximize benefits and minimize risks? What are the directions of future research? What is the evidence that ECT is effective for patients with specific mental disorders? What are the risks and adverse effects of ECT? What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? How should ECT be administered to maximize benefits and minimize risks? What are the directions of future research? The first question, what is the evidence that ECT is effective for patients with specific mental disorders? The first question, what is the evidence that ECT is effective effective for patients with specific mental disorders. Published controlled studies of ECT permit evaluation of its short-term efficacy in severe major depressions, delusional and endogenous, in acute mania, and in certain schizophrenic syndromes. The available controlled clinical trials do not extend beyond the treatment of the acute episode, but for about 4 weeks. These studies are difficult to interpret because they have used differing diagnostic systems and research designs. Further, they have measured outcome only in terms of symptom reduction and not quality of life and social functioning. Depression. Studies of ECT in depression have used various control conditions for comparison, including, quote, sham ECT, that is all the elements of the ECT procedure except the electric current, tricyclic antidepressants, monoamine oxidase inhibitors, combinations of antidepressants and neuroleptics, and placebos. The efficacy of ECT has been established most convincingly in the treatment of severe delusional and endogenous depressions, which make up a clinically important minority of depressive disorders. Some studies find ECT to be of at least equal efficacy to medication treatments, and others find ECT to be superior to medication. Not a single controlled study has shown another form of treatment to be superior to ECT in the short-term management of severe depressions. It must be noted, however, that those studies that found ECT to be superior to medication do not document any advantage for ECT beyond the short term. Moreover, the available evidence suggests that relapse rates in the year following ECT are likely to be high unless maintenance antidepressant medications are subsequently prescribed. Several studies suggest that ECT reduces symptoms in severely depressed patients who previously have not responded to adequate trials of antidepressant medication. The literature also indicates that ECT, when compared to antidepressants, has a more rapid onset of action. Delusional depression. ECT is highly effective in the treatment of delusional depression. It is superior to either antidepressants or neuroleptics used alone, and is at least as effective as the combination of antidepressants and neuroleptics. ECT is often effective in patients who have previously failed to respond to medication. The duration of therapeutic effect beyond the initial acute episode is not clear. Endogenous melancholic depression. The severe endogenous melancholic depressions are characterized by early morning awakening, marked weight loss, psychomotor retardation and/or agitation, diurnal variation, and lack of reactivity. ECT is at least as effective as tricyclic antidepressants and more effective than sham ECT in the short-term treatment of these severe endogenous melancholic depressions. ECT appears to be more effective than monoamine oxidase inhibitors in the treatment of severe depressions, but available studies have generally used relatively low MAOI doses. The long-term efficacy of ECT with endogenously depressed patients is unknown. There is evidence for the efficacy of ECT in those endogenous depressives who have not responded to an adequate trial of antidepressants. Other depressions. The majority of depressed persons encountered in medical and psychiatric settings do not have the severe endogenous melancholic or delusional depressions described above. ECT is not effective for patients with milder depressions, that is, dystonic disorder, neurotic depression, and adjustment disorder with depressed mood. While patients with major depression, that is non-endogenous, non-melancholic, have not been directly studied using the current DSM-3 nomenclature, their similarity to other, less severe forms of depression suggests that ECT would not be effective for them. Acute manic episode. ECT and lithium appear to be equally effective for acute mania, and both are superior to hospitalization with no somatic therapy. A treatment regimen in which ECT is used for the acute episode, followed by lithium maintenance, does not appear to be associated with increased risk of early relapse compared with lithium treatment alone. Schizophrenia. Although neuroleptics are the first line of treatment for schizophrenia, ECT may sometimes be effective. ECT is generally more effective for those schizophrenics with a shorter duration of illness, a more acute onset, and more intense affective symptoms. ECT has not been useful in chronically ill schizophrenic patients. Although ECT is frequently advocated for treatment of patients with schizophreniform psychoses, schizoaffective disorders, and catatonia, there are no adequate controlled studies to document its usefulness for these disorders. Other disorders. There are no controlled studies supporting the efficacy of ECT for any conditions other than those designated above. That is, delusional and severe endogenous depression, acute mania, and certain schizophrenic syndromes. What are the risks and adverse effects of ECT? That's question number 2. What are the risks and adverse effects of ECT? That's question number 2. To maximize the benefits of ECT and minimize the risk, it is essential that the patient's illness be correctly diagnosed, that ECT be administered only for appropriate indications, and that the risks and adverse effects be weighed against the risks of alternative treatments. Risks and adverse effects of ECT can be divided into 2 categories. Those that can be substantially reduced by the use of appropriately trained staff, best equipment, and best methods of administration, and 2, those such as persistent memory loss and transient post-treatment confusion, which can be expected even when an optimal treatment approach is used. In this report, we will focus on the risks of adequate treatment, which now includes the use of short-acting anesthetics, muscle relaxants, oxygenation, and a well-trained staff and modern equipment. In the early days of ECT, mortality was a significant problem. The commonly quoted mortality rate in the first 2 decades was 0.1% or 1 per thousand. Over the years, safer methods of administration have been developed. Present mortality is very low. In the least favorable recent study series reported, there were 2.9 deaths per 10,000 patients. In another series, 4.5 deaths per 100,000 treatments were reported. Overall, the risk is not different from that associated with the use of short-acting barbiturate anesthetics, such as those used for dental procedures. Nevertheless, the potential for death from improperly administered anesthesia is ever present and should be considered when evaluating the setting for performing ECT. In the past, up to 40% of patients suffered from various complications, the most common being vertebral compression fractures. With present techniques, these risks have been virtually eliminated. In one large study of almost 25,000 treatments, a complication rate of 1 per 1,300 to 1,400 treatments was found. These included laryngospasm, circulatory insufficiency, tooth damage, vertebral compression fractures, status epilepticus, peripheral nerve palsy, skin burns, and prolonged apnea. During the few minutes following the stimulus, profound and potentially dangerous systemic changes occur. First, there may be transient hypotension from bradycardia, caused by central vagal stimulation. This may be followed by sinus tachycardia and also sympathetic hyperactivity that leads to a rise in blood pressure, a response that may be more severe in patients with essential hypertension. Intracranial pressure increases during the seizure. Additionally, cardiac arrhythmias during this time are not uncommon, but usually subside without sequelae. Thus, certain patient groups that would be adversely affected by these manifestations are at increased risk. Central nervous system effects can be divided into 2 categories: the immediate consequence of the ECT seizure and the more enduring effects whose severity is affected by the treatment course. Immediately after awakening from the treatment, the patient experiences confusion, transient memory loss, and headache. The time it takes to recover clear consciousness, which may be several hours, varies depending on the individual differences in response, the type of ECT administered, and the spacing and number of treatments given. The severity of this post-ECT syndrome is greatest after bilateral sine wave treatment and least when non-dominant unilateral pulse ECT is administered. Severity also appears to be increased by long procedure duration, closer spacing of the treatments, increasing dosage of electrical stimulation, and each additional treatment. With a small number of treatments generally used, however, the number of treatments may not have a significant effect on the nature of the acute confusional state. Depressive disorders are characterized by cognitive defects that may be difficult to differentiate from those due to ECT. It is, however, well established that ECT produces memory deficits. Deficits in memory function, which have been demonstrated objectively and repeatedly, persist for several months after the termination of a normal course of ECT. Severity of the deficit is related to the number of treatments, type of electrode placement, and nature of the current. Greater deficit occurs from bilateral placement than from unilateral placement, but unilateral treatment may be less effective. Sine wave current has been found to impair memory more than pulse current. Enduring or permanent gaps in memory have been reported to occur for events occurring during the 6-month period before ECT, retrograde amnesia, and during the 2-month period after treatment, anterograde amnesia. Although the ability to learn and retain new information may return to normal in several months after the termination of ECT, significant treatment-related gaps in memory may persist. The extent of the memory deficit varies from one patient to another. Because there is also a wide difference in individual perception of the memory deficit, the loss can be extremely distressing to some and of little concern to others. Many patients complain their memory is not as good as it was formerly for as long as 3 years after treatment, although this deficit has not been established by neuropsychological testing. There is no consistent evidence of change in other cognitive functions such as attention or learning. There are other possible adverse effects from ECT. Some patients perceive ECT as a terrifying experience. Some regard it as an abusive invasion of personal autonomy. Some experience a sense of shame because of the social stigma they perceive as attaching to ECT, and some report extreme distress from persistent memory deficits. The panel heard eloquent testimony of these attitudes from some patients who have been treated with ECT. It is clear, however, that these attitudes are not shared by all ECT patients. The panel also heard moving testimony from former patients who regarded ECT as wholly beneficial and life-saving experience. There are insufficient systematic studies to permit any definitive assessment of the prevalence of these various perceptions among ECT patients. Numerous studies have been conducted in animal models of ECT. Many of these suffer from methodological shortcomings. In studies that have been controlled for fixation artifacts, hypoxia, and other methodological problems, neuronal cell death has not been detected. Cerebral vasospasm and alterations in capillary permeability are of short duration and of insufficient magnitude to lead to neuronal cell death. The precise mechanism of the anterograde and retrograde memory deficit has not been established. It may represent alterations in neuronal function that are not detectable with present methods. Computerized axial tomography or CAT studies of patients who have had ECT are very preliminary and open to alternative interpretations. Studies of in vitro brain metabolism with positron emission tomography, PET, and studies of tissue change detectable by magnetic resonance imaging, MRI, remain to be done. The third question. What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? The third question. What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? The consideration of ECT is most appropriate in those conditions for which efficacy has been established. Delusional and severe endogenous depressions, acute mania, and certain schizophrenic syndromes. ECT should rarely be considered for other psychiatric conditions. The decision whether to offer ECT to an individual patient should be based on a complex consideration of advantages and disadvantages for ECT and for each treatment alternative. Whether or not to use ECT should be based on a thorough review of severity, medical indications and contraindications, and non-responsiveness to other treatments. It should be emphasized that for certain patients with very specific and narrow indications, ECT may be the only effective treatment available. The panel wishes to assure that ECT is only administered for the benefit of individual patients. Institutional factors such as financial pressures created by prospective systems or staff convenience should play no role in the decision to administer ECT. Severity. Given a diagnosis for which the efficacy of ECT has been established, the immediate risk of suicide, when not manageable by other means, is a clear indication for the consideration of ECT. Acute manic episodes, especially when characterized by clouded sensorium, dehydration, extreme psychomotor agitation, high risk for serious medical complications, or death through exhaustion, and non-response to pharmacological interventions are also clear indications for ECT. The severe and unremitting nature of the patient's emotional suffering or extreme incapacitation are also important considerations. Medical indications and contraindications. The patient's medical status is often a determining consideration in the use of ECT. ECT may be necessary when the patient has medical conditions that preclude the use of tricyclic antidepressants, monoamine oxidase inhibitors, lithium, and neuroleptics. Severe depression or psychosis during the first trimester of pregnancy may also suggest the use of ECT. Conversely, space-occupying lesions in the brain, increased intracranial pressure, a recent history of myocardial infarction, and aneurysm are contraindications for ECT. A personal history of ECT non-responsiveness or debilitating side effects, medical or psychological, are also important contraindications. Non-responsiveness to other treatments. ECT should be considered when alternative pharmacological and or psychotherapeutic treatments have been given an adequate trial without efficacious response. In treatment non-responsive patients, factors such as severity, the natural course of the patient's illness, and the risk of worsening the course of illness, for example, exacerbation of the course of bipolar illness by antidepressant medication, need to be taken into account. Informed consent. When the physician has determined that clinical indications justify the administration of ECT, the law requires and medical ethics demand the patient's freedom to accept or refuse the treatment to be fully honored. An ongoing consultative process should take place. In this process, the physician must make clear to the patient the nature of the options available and the fact that the patient is entitled to choose among these options. No uniform shopping list, quote, can be drawn up regarding the matters that should be discussed by the patient and physician to assure a fully informed consent. They should discuss the character of the procedure, its possible risks and benefits, including full acknowledgement of the attendant uncertainties, and the alternative treatment options, including the option no treatment at all. Special individual needs may also be relevant to some patients. For example, personal situations that require rapid recovery to facilitate return to work and to reduce family disruption. In all matters, the patient should not be inundated with technical detail. The technical issues should be translated into terms meaningful and accessible to the patient. It is not easy to achieve this ideal of informed consent in any aspect of medical practice, and there are special difficulties that arise regarding the administration of ECT. In particular, the patients for whom this procedure is medically appropriate may be suffering from a severe psychiatric illness that, although not impairing their legal competency to consent, may nonetheless cloud their judgments in fully weighing all of the available options. Such judgmental distortion does not justify disregarding the patient's choices. Rather, it makes all the more important that physicians strive to identify and clarify the options that the patient alone is entitled to exercise. The consent given by the patient at the outset of treatment should not be the final exchange on this issue, but should be re-examined repeatedly throughout the course of the treatment. These periodic reviews should be initiated by the physician and not depend on patient initiative to, quote, rescind consent. There are several reasons for this repeated consenting of procedure. Because of the relatively rapid therapeutic effect of the procedure itself, the patient, after initial treatment administrations, is likely to have enhanced judgmental capacities. The risk of adverse effects increase with repeated treatments. But the question of continuing treatment presents a possible change, risk-benefit assessment for the patient. And because of the short-term memory deficits that accompany each administration of ECT, the patient's recollection of the prior consenting transaction itself might be impaired, so that repeated consultations reiterating the patient's treatment options are important to protect the patient's sense of autonomy throughout the treatment process. Moreover, if the patient agrees, his or her family should be involved in each step of this consultative process. In some cases, a patient will lack adequate legal capacity to consent to the proposed procedure, although such patients will most likely constitute a small minority of all patients for whom ECT is an appropriate option. In such cases, court proceedings are necessary if treatment is to be provided. Legislation in a few states provides that ECT may, in no circumstances, be provided to an involuntarily committed patient. The panel believes that such provisions are unduly restrictive and make it impossible for patients who might obtain substantial benefit at acceptable levels of risk from ECT that they could not obtain from any alternative treatment modality. It may be desirable for physicians with patients for whom the prospect of ECT is a foreseeable but not immediate possibility to discuss this in advance with the patient when his or her judgment appears least compromised by the underlying disease process. Such advanced discussion would serve as a non-binding guide both to the patient and physician and would be another means to enhance the patient's autonomous choice in weighing the risks and benefits of this procedure and its alternatives. Question 4. How should ECT be administered to maximize benefits and minimize risks? Question 4. How should ECT be administered to maximize benefits and minimize risks? Once the patient and physician have decided that ECT may be indicated, the patient should undergo a pre-treatment medical examination that includes a history, physical, neurological examination, EKG, chest films, and laboratory tests. Medications that affect the seizure threshold should be noted and decreased or discontinued when clinically feasible. Monoamine oxidase inhibitors should be discontinued 2 weeks before treatment, and patients should be essentially lithium-free. Severe hypertension should be controlled before beginning treatment. Because some patients with compromised cardiovascular status will be receiving ECT, cardiac conditions should be evaluated and monitored closely. Educate the patient and the family through discussion and written and or audio-visual material describing the procedure as necessary prior to obtaining written informed consent. An area should be designated for the administration of ECT and for supervised medical recovery from the treatment. This area should have appropriate healthcare professionals available and should include equipment and medications that could be used in the event of cardiopulmonary or other complications from the procedure. An anesthesiologist, or anesthetist experienced with brief anesthetic procedures should administer the anesthesia. The treatment team should include nursing personnel trained in ECT procedures and recovery. ECT is ordinarily given in the early morning after an 8 to 12-hour period of fasting. Atropine or another anticholinergic agent is given prior to the treatment. An intravenous line is placed in the peripheral vein, and access to this vein is maintained until the patient is fully recovered. Methylhexatol is given first, followed by succinylcholine for muscle relaxation. Ventilatory assistance is provided with a positive pressure bag using 100% oxygen. The EKG, blood pressure, and pulse rate should be monitored throughout the procedure. Stimulus electrodes are placed either bifrontotemporally, bilateral, or with one electrode placed frontotemporally and the second electrode placed on the ipsilateral side unilaterally. Bilateral ECT may be more effective in certain patients or conditions. It has been established, however, that unilateral ECT, particularly in the non-dominant side, is associated with a shorter confusional period and fewer memory deficits. Also, a brief pulse stimulus is associated with fewer cognitive defects than the traditional sine wave stimulus. Seizure threshold varies greatly among patients. Therefore, the lowest amount of electrical energy to induce an adequate seizure should be used. Seizure monitoring is necessary and may be accomplished by an EEG or the cuff technique. In unilateral ECT, the cuff should be on the same side of the electrodes to ensure that a bilateral seizure occurred. Further work integrating these variables is necessary to maximize efficacy and minimize side effects. The numbers of treatments in a course of therapy varies. 6 to 12 treatments are usually effective. In the United States, the usual frequency is 3 times weekly. In the United Kingdom, the standard practice is 2 treatments weekly. Regressive ECT, a large number of treatments given within a short period for the purpose of achieving a persistent organic brain syndrome is no longer an acceptable treatment form. Multiple monitored ECT, several seizures during a single treatment session has not been demonstrated to be sufficiently effective to be used. There are no controlled studies on the periodic use of ECT as a maintenance regimen. Following ECT, most depressed patients should be maintained on antidepressant medication to reduce relapses. The panel is concerned that there are only limited data on the manner and extent of ECT administration in the United States and on the training of personnel involved in it. A national survey should be undertaken to assemble basic facts about the status of ECT treatment. Medical school curricula should include education in the use of ECT. Psychiatric residency programs should include complete ECT training, indications, contraindications, risk, clinical management, informed consent, and the evaluation of outcome. The American Board of Psychiatry and Neurology should include questions about ECT in its oral examination. The panel believes it is imperative that appropriate mechanisms should be established to ensure proper standards and monitoring of ECT. Hospitals and centers using ECT should establish review committees modeled on other medical surgical review committees and should formulate rules and regulations to govern the privileging of physicians given their treatments. Stringent peer review, consistent with Joint Commission for the Accreditation of Hospital Standards, should monitor ongoing utilization of ECT. Periodic inspection of the equipment is also essential. As experience accumulates, consideration should be given to the adequacy of existing monitoring and review mechanisms. 5. What are the directions for future research? 5. What are the directions for future research? ECT has been under-investigated in the past. Among the most important immediate research tasks are initiation of a national survey to assemble the basic facts about patient attitudes and responses to ECT. Better understanding of negative, positive, and indifferent responses should result in improved treatment practices. Identification of the biological mechanisms underlying the therapeutic effects of ECT and the memory deficits resulting from the treatment. Better delineation of the long-term effects of ECT on the course of affective illnesses and cognitive function. Precise determination of the mode of electrode placement, unilateral versus bilateral, and the stimulus parameters, form, and intensity that maximize efficacy and minimize cognitive impairment. Identification of patient subgroups or types for whom ECT is particularly beneficial or toxic. Conclusion. Electroconvulsive therapy is the most controversial treatment in psychiatry. The nature of the treatment itself, its history of abuse, unfavorable media presentations, compelling testimony of former patients, special attention by the legal system, uneven distribution of ECT use among practitioners and facilities, and uneven access by patients all contribute to the controversial context in which the consensus panel has approached its task. The panel has found that ECT is demonstrably effective for a narrow range of severe psychiatric disorders in a limited number of diagnostic categories. There are, however, significant side effects, especially acute confusional states and persistent memory deficits. Proper administration of ECT can reduce potential side effects by also providing for therapeutic effect. The physician's decision to offer ECT to a patient and the patient's decision to accept it should be based on a complex consideration of advantages and disadvantages of ECT compared with alternative treatments. An ongoing consultative process requiring time and energy on the part of both patient and physician should occur. Much additional research is needed into basic mechanisms by which ECT exerts its effect. Studies are also needed to better identify subgroups for whom the treatment is particularly beneficial or toxic, and to refine techniques to maximize efficacy and minimize side effects. Surveys should be conducted on the practice of ECT in the United States. These recommendations reflect the consensus of the panel. We have been careful to narrowly delineate when and how, in our judgment, ECT should be administered. To prevent misapplication and abuse, it is essential that appropriate mechanisms be established to ensure proper standards and monitoring of ECT. Thank you.
One electroshock treatment can equal the energy of 3 pistol shots to the head.
Dr. Rose accepted 2 pieces of literature for reference. I would hope and you might make copies available for the panel. We're talking about having a police factor information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. The other, and pardon me for the emotional content of it, I also included a current Winchester ammunition catalog because it shows the energy with which the bullets have. Now that's emotional, and I don't really want to bring that up. But running this machine at its maximum brings 201 joules of energy. That is 148 foot-pounds. If you're interested in actually understanding like the truth in lending and what they're talking about, 1 joule is 0.07376 foot-pounds. But what this means is this device, when operated at its maximum capacity, will lift a 1 pound weight 148.7 feet. The energy contained in that is equivalent to 3 25 caliber pistol slugs. Now that's almost instantaneous entering the brain. This takes a half a second. Now that is just pure factor data. To give that lifting of 1 pound energy equivalence in informed consent, how could you not do that? And if you're going to give a procedure, the total energy and the total time are the physical parameters that characterize the device. How could you not include that information? And if a doctor prescribes a drug, he has to record the prescription. Why isn't the total time and the total energy recorded? This has been an experimental hazardous device for years now. Why hasn't this information been gathered that we could be talking with concrete objective facts rather than subjective opinions of psychiatrists and patients?
1 electroshock treatment can equal the energy of 3 pistol shots to the head.
All right, out with your gun.
Huh?
Out with your gun.
Okay, this won't hurt. It'll be over in just a moment. Uh-huh. What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it. That's right. Just bite down.
Huh?
Now bite down on it.
Good. Are you ready? Here we go.